Thank you. My name's Caleb Alexander. I'm delighted to be here. I hope you enjoyed that highlight reel. I'll never forget Congressman Kennedy's impassioned plea to do a checkup from the neck up,
Providing access to life-saving drugs to 5 million
and
people
his
with HIV/AIDS.
and his ability to articulate his own experience with addiction and his navigation of the treatment system. We're going to be bringing some chairs up for our panelists, and I'll invite the panelists up in a minute. But I want to begin just by emphasizing the enormous number of people that it took to make today possible, and I want to acknowledge literally dozens of people. I'm not going to run through every single name, but I want to thank the Clinton Foundation, Rain Henderson, Alex Chan, Ariel Grand and colleagues, President Clinton, and all of the colleagues at the Clinton Foundation. Dean Clagg, my chair, David Celentano, never hurts to thank your boss. Ellen McKenzie and Josh Sharfstein and other school leaders for your commitment to this issue. Director Botticelli and colleagues from the Office of the National Drug Control Policy. Faculty and staff from the Center for Drug Safety and Effectiveness and the Center for Injury Research and Policy, especially Eleanor Lucas and Eric Schulman and Susan Morrow, who worked tirelessly to make today possible. The working group leads and signatories and others who contributed to the report. Andrea Galen and Shannon Frateroli, the co-editors of the report and faculty co-organizers for this event. I really can't imagine a smarter and more committed and more down-to-earth group of faculty to work with, and that's among a pretty down-to-earth cohort of faculty here at the school, but really they were a delight. And last but definitely not least, the school's Department of External Affairs and multimedia groups and environmental services. You know who you are and what you do, and you're really good at it, and on behalf of all of the signatories, I just want to express our gratitude for your contributions to making today possible. So before we do anything else, please join me in a round of applause. Great, and what a great first hour. So Josh, thank you again, and it was really lots. I mean, I joked to Dean Clagg that you were taking a lot of my questions, but I have a feeling the people in the room will have a few more, and we're still getting them live, so if you want to email them, you can send them to rxtownhall@jhu.edu. If you want to tweet them, you can tweet them, and we'll also pass some microphones during the remaining time. Let me just introduce the panelists, and if I can have all of you come up and take seats, that would be terrific. We have 6 experts. Alex Kahana led the working group on prescribing guidelines. He's Director of Medical Affairs at the Center for Lawful Access and Abuse Deterrence, closest to me. Former Professor and Chief of the Division of Pain Medicine at the University of Washington, an expert in the measurement-based care as a standard of care in pain medicine, and decorated combat medical officer holding degrees in bioethics, philosophy, and theology. John Eady, who led the working group on prescription drug monitoring programs. He's the director of the PDMP Center of Excellence at Brandeis. He has 44 years of experience in management, executive, and consulting capacities in public health. He co-founded and has served as the president of both the Alliance of States with Prescription Monitoring Programs and the National Association of State-Controlled Substances Authorities. Pat Gleason, who is right there, he led the group on pharmacy and PBMs. He's Director of Health Outcomes at Prime Therapeutics, Adjunct Professor of Pharmacy at the University of Minnesota. He leads Prime Therapeutics' Clinical Health Outcomes Assessment Team and is a national expert in the design and evaluation of pharmacy benefit management programs. Christopher Jones, who you now know, one of our stars from the first hour, was ambitious enough to take on not one but leading 2 different working groups. So one was focused on engineering strategies and one was focused on naloxone distribution programs. He, as you heard, is the director of the Division of Science Policy at the Assistant Secretary for Planning and Evaluation at HHS. He's previously been a senior advisor in the FDA Commissioner's Office and led the CDC's Drug Abuse and Overdose Network, as well as completed a 1-year detail to the White House ONDCP. That's what the office that Director Botticelli directs. Andrew Kolodny led the group on addiction treatment. As with Alex Kahana, he's trained as a physician and he's Chief Medical Officer at Phoenix House and Executive Director and co-founder of Physicians for Responsible Opioid Prescribing. He was previously Chair of Psychiatry at Maimonides Medical Center in New York City and has extensive experience in public health interventions for the New York City Department of Health. And last but definitely not least, Andrea Gielan. She's here from Hopkins, of course, and led with Shannon Frateroli the Community-Based Prevention Strategies Working Group. She directs the Center for Injury Research and Policy. In addition to Shannon and myself, she was one of the 3 co-editors of the report, as I mentioned. She's a professor of health policy and management, health behavior society, and population, family, and reproductive health, and is a nationally renowned expert in injury prevention. So I've asked the panelists to keep their answers pretty crisp so that we can get through, so that we can discuss a lot. We want to have a lot of exchange with all of you. We want to continue taking questions from around the country. I have 1 or 2. I'll kick things off, but after that, I'm happy to open things up. And that's about all I have. So we've heard a lot already about this epidemic. So panelists, I'd like to just give you a chance to start off with. Both to respond to what you've heard, if there's anything that in particular that is on your mind, and or to choose a top recommendation from your working group and just briefly discuss, if you had to choose just one that you thought held the most promise, what would it be? So some combination of brief reactions from the first hour and top recommendations.
You want to go down the line?
Any way you like it.
So, last year I recall the economists that you invited discussed this problem and mentioned that this isn't the type of problem for which we can find a magic bullet. What we need is a magic buckshot because it's so complicated and there's so many elements necessary to bring it under control. So what I'm saying is I can't really name one single recommendation in the report that would be that's my favorite. What I would say, though, is I would frame our opioid problem as an epidemic of opioid addiction. I think the reason that we've got overdose deaths at record high levels and why heroin is flooding into non-urban areas, and all of the problems that we're facing are related to a sharp increase in the number of people with opioid addiction. Since I would frame it that way, I would say that the recommendations that are going to be the most effective are going to be the recommendations that lead to preventing new cases of opioid addiction through more cautious prescribing, and the recommendations that lead to more people with this condition accessing effective treatment so the condition doesn't kill them.
Great, thank you.
I think first of all, the session we just heard was very enlightening and very worthwhile. I think this particular report is the single most comprehensive treatise on the entire epidemic that's been put out so far, and it identifies the breadth of effort that needs to be taken to solve it. My area of expertise is in prescription drug monitoring programs, but it is only one of many that have to be addressed areas. As to the specific recommendation, that the first recommendation of our group is that the states adopt the mandatory use of prescription monitoring program data by prescribers before they issue not only their first prescription for opioids, but subsequent prescriptions. There's some debate about whether it should be every prescription, and New York right now mandates it's every prescription. Kentucky has gone to 3 months. There's one state that's gone to a year, and a couple of states that don't mandate anything afterwards. But it's very clear that given the nature of addiction, that if it's not before the first prescription and then repeated thereafter, that there's no way for prescribers to know what's going on. And I won't go into the depths of the details, but fundamentally, prescribers are blind to what's going on with their patients in this area. There's far too much deception of prescribers going on by people who are intentionally or unintentionally trying to prevent them from knowing what other drugs they may be getting. And if prescribers don't take the time to get the data, and they won't unless they're mandated to, that's clear, they won't know what's going on. But if they do and when they do, remarkable changes occur, and that's been uniform now in the states that have implemented it.
Thank you. Alex?
I would say, first of all, thank you for inviting me and being part of this group. I would say instead of the most important recommendation, I would look at the first recommendation. In other words, that as long as we don't fulfill that recommendation or those recommendations, other recommendations will have some difficulty in having an impact. And those would be indeed the first recommendations, 1, 2, and 3. And the idea behind it is that at the end of the day, the root cause of all this is a very impoverished therapeutic dialogue that we have when we go to see the provider. Walk in, how are you doing? Not so well. Okay, take this, get out of my office. And so what we need in terms of policy, very simple, guidelines on how to prescribe correctly. Have a threshold so the state will give telehealth services if you don't have access to specialty care, mandated PDMPs, and the last, of course, is to measure pain, mood, and function at every clinical encounter so that you can know that things are going better.
Okay, great. So I'm going to take moderator's prerogative if I can and ask you. Oh, go ahead, Andrea. Go ahead.
I preferred your question about our reactions to what we heard in the first hour over picking one, and I was really struck by how many times the idea about the patient and what the patient needed came up, but not in the sense of what about activating the patient? Don't put it all on the clinician or the provider. What are we doing in communities to have educated consumers so when they walk into the doctor's office, they have some information, they have some questions, and when they do walk out with a prescription, it's a decision that was made between the doctor and the patient that was a well-informed decision, and that patient knows how to store those medications, how to dispose of them, and how to protect their children, especially their teenagers, from accessing them. And that was a lot of what we talked about in the community guidelines, so I think I did hit on my favorite recommendations after all.
So as the representative of the insurance side of things, I do want to say something about what I heard earlier, and that is that the insurers want to pay for addiction treatment. We want to pay for Suboxone and Methadone. We also want to ensure that those individuals that are receiving those therapies are using both of those in conjunction, and they're not using just one or the other. That they're receiving both Suboxone and also are enrolled and involved in addiction treatment ongoing. So I just want to tell the room that as a Confined Therapeutic Center, we're owned by Blue Cross Blue Shield plans, that we want to pay. And actually, I would encourage you to read the Boston Globe story from the 11th of this month about how much the insurance industry is indeed paying for and encouraging and actively engaging their members or individuals that are under insurance to be a part of addiction programs. So that being said, I will say that one of the top priorities from our group is that the prescription drug monitoring programs that are out there right now that are state-run do not allow insurance industries to access the data. And our programs that we have actively engaging and informing physicians and prescribers about overuse of controlled substances, in particular opioids. We can see, by allowing us to see into prescription drug monitoring programs, we'll be able to see those prescriptions that are paid for by cash to better inform the prescribers about their patients and the overuse of opioids and controlled substances.
Great, thank you. And Chris, can you say just a little bit about the engineering strategies? We didn't hear that much about it during the first hour, and I think for some of us, we are not that familiar with what that means or how engineering plays a role in trying to improve the safety of prescription opioid use. Andrea may also have thoughts about that from the perspective of injury prevention, but do you want to start?
Sure. So I was going to say my takeaway from the first session is that Chris Jones is very charming. I think, so engineering strategies are sort of taken from injury prevention generally. So you think about motor vehicles or gun safety and thinking about how do we engineer safer products. And so the idea here was, there's been a lot of focus on PMPs, on prescribing practices, on treatment and other things, and not so much about the engineering strategies around the products. And some work on abuse deterrent products, but also packaging and, from a perspective of unintentional access, or people being able to take other people's medications, so biometric monitoring, those types of things. There's some work in that space. FDA has been interested in that. They issued a call for information from people who are working in that space in the last year to better understand how are people looking at packaging and other engineering strategies? So when you get a product from the pharmacy right now, you get an amber vial with a top that's pretty easy to get off, and you have arthritis or something, you might ask for an easy open top, so it's really easy to get off. And so thinking about, are there products that dispense at particular times, or that are difficult to get into, or that, again, you have to do a fingerprint, or can be electrically monitored remotely to see when people are accessing, and provide that feedback to providers. So it's trying to take from the injury prevention world to say this also has application here.
Can I brag on our engineering students in mechanical design here at the school? We know that those child-resistant caps were very key in reducing early poisonings from baby aspirin years ago with little kids. But we're in a whole different place now with this kind of medication, and it's the older kids and the teenagers, and those child-resistant lids aren't going to help them. So what our engineering students did was create a tamper-resistant, personalized pill dispenser that is virtually indestructible, that requires a pharmacist to put the pills in and lock it, and then requires a fingerprint of the actual patient to dispense it. Now, it's a prototype and it's just at the very beginning, but I think we have to think outside of the box to come up with new and innovative ideas. So good for the engineering students, and we're hoping that more will follow.
Thanks. We'll move to questions from the audience in just a minute, but any other comments about engineering strategies? Andrew, do you have any thoughts about that? Or
I think that these are very worthwhile endeavors, but we also have to recognize that patients can be harmed by opioids even when taken exactly as prescribed, and young people are being overprescribed opioids after wisdom teeth come out or for sports injuries. And the focus on getting parents to lock their medicine chests so that their kids won't get these pills, or to have engineering solutions so that the kids don't get their hands on the pills, sort of sometimes may miss the fact that the parents themselves taking opioids exactly as prescribed can become addicted. And in fact, the overdose death rate in the United States is highest in individuals 45 to 54 who are receiving legitimate prescriptions from doctors.
thanks. Are you waiting to ask a question? Microphone runner?
Yes, I am.
Okay, would anyone like to ask a question? Yeah, we have some people over here. Yeah.
Thank you for coming today. I want to ask a question from a research perspective. Right now, if you want to study addiction abuse, you cannot use Medicaid, which is one of the largest payers for addiction treatment, or Medicare data. You cannot access data with claims of treatment for substance abuse disorder, including alcohol use, or any diagnosis. So what is being done and what can be done to restore access to substance abuse data in Medicare and other government databases?
So the question is about access to federal databases.
Figure the HHS representative has to answer that one, right?
Say that again?
I said it would make sense that the HHS person would attempt to answer
Right.
this question.
Okay.
So I'll have to get back on a specific answer. I do not personally know what steps are being taken to address this. I know that there were some legal issues about what type of data could be disclosed. It previously had been disclosed. I think there was a reinterpretation of the legality of disclosing that information. So I'm not an expert in this area, so I would have to get back to you. But I will provide a response to Johns Hopkins, and they can put that forward.
Great, thank you so much.
I would say something that is almost heresy to say in the School of Public Health, so from this environment I understand why. But as a practicing physician, I would recommend to venture maybe a different approach, and that is, instead of trying to find, go and dive into the troves of data that exist and to figure out that you are either accepting or refuting null hypotheses, is actually to go out to clinics themselves who see patients and try to gather everyday data through either patient-reported outcome or passive wearable technology. I'm wearing this, I know what's going on with me, and try to understand in terms of generalizability what is going on in the real world. And the reason why I'm saying this is not, of course, to change anyone's research trajectory, But I think that what would really change or make a difference in the way we use data is more of bringing actionable information to the fingertips of either prescribers or the patients themselves. And we can create patients behavior modification only if they see in front of their eyes dashboards that have that actual data that says, oh my God, I did not realize that this is happening to me. Or prescribers who see through the PDMP, oh my God, I did not know that this is what's happening. Because at the end, and I'll, by the risk of becoming redundant, everything is important here, but not everything has the same importance. And it is all about a very impoverished therapeutic dialogue that prescribers have with their patients of how you doing, fine, okay, take this and get out of my office because I need to continue my day.
So while thank you for that comment. While you have the mic, I want to ask about the CDC prescribing guidelines also, which many of you may know the CDC is coming out with new guidelines regarding opioid prescribing in January. And can you speak briefly to the degree to which there's harmony or the recommendations that your working group developed highly consistent with the CDC's guidelines? Are there areas where there are substantial differences, and can you just briefly speak to that?
Well, very briefly, is that there is harmony. There is harmony. I would say, and I would even go one step further and say that even the guidelines that we spoke in our work group, that is of course taken by Washington State prescription guidelines, had most of it also through a consensus through all the other savant societies to a large extent. I think that wherever there is some disharmony is where there's angst of what will be the unintended consequences of such, guidelines for prescribers. But I think that if we look at it at the optic that good treatment is not sine qua non with getting my Percocet, but rather, like Chris correctly said, is the availability to a multimodal approach, and that patient will say, hey, I also want access to my yoga and Tai Chi. I want my access to a plant-rich based nutrition. I want my access to sleep hygiene and smoking cessation. So I think that if we kind of dissociate this, we're concentrating only on the opioid, rather understanding that this is a surrogate measure, a very omnipresent surrogate measure to a dysfunctional therapeutic pathway.
Okay, thank you. Are those covered services, Pat?
I believe so. I would like to add that as pharmacy benefit managers, and I've spoken with a number, we are in support of the guidelines that the CDC has proposed, the draft version that's out there. And I'll just say also that if you have diabetes and you're started on insulin, you're started on a short-acting insulin. You're not started on a long-acting insulin. Opioids have a very narrow therapeutic range. We all know that you can die of an overdose. So it doesn't make sense to start an opioid with a long-acting opioid, and yet we see at the lives that we insure, 1 in 10 individuals, their first prescription is a long-acting opioid. That doesn't make sense, and that's one of the reasons for the guidelines. Because right now, prescribers are still not quite understanding the narrow therapeutic range that they're dealing with opioids.
Thank you. There were a few other hands up here. Maybe we can take 2 or 3 questions, and then we'll sort through them. If you can pass the microphones. We'll take 2 questions at a time, and then let the figure out who.
Great. Thank you so much, and for the comments, for the prior hour. Speaking about kind of training, because I've heard a lot, with the panel online, as well as you all have talked about education, and really the part of this is kind of that dysfunctional or inadequate therapeutic relationship between a patient and a doctor. I wondered if you could actually comment on educational efforts that are then being made to really broaden and make sure that physicians, dentists, kind of all healthcare professionals, all the way from schools into residency programs and ongoing training, that really around chronic pain management as well as addiction, because it seems to me that we have pockets kind of that are happening across the country. Even Johns Hopkins School of Medicine is not right across the street, and but there's not uniformity, and that until we really get the AAMC, until we get the American Board of Medical Specialties kind of push to really incorporate this as standardized core competencies, that we're going to have kind of these piecemeal here, there, and everywhere, when it really needs to be kind of across the board.
Thank you. So the question, we'll take one more question before we take that one, if there was another hand up. And then, but this first question was about standardizing training and training across the continuum of providers and different healthcare settings. Yeah.
Again, thank you for coming. Mine is a short question. So we talked about prevention. How can we prevent addiction from developing in chronic pain patients who are prescribed opioids chronically? We know how to do that, and if we don't, what are we doing about that?
Great questions. Andrew, do you want to begin?
Yeah. Actually, I think the questions are related, because the bulk of the education that's available right now for prescribers are FDA REMS programs, where the curriculum is set by the FDA, and in fact industry had a lot to say about that curriculum. And I think the programs are generally awful. Some of the professional societies that deliver them do a better job with them. For example, the American Society of Addiction Medicine, their REMS programs are okay. But the problem is the curriculum itself implies that we can teach doctors exactly what you're asking about. We can teach them safe and effective opioid prescribing for chronic pain, that if they properly select their patient using a risk assessment tool, and then if they put the patients with greater risk of getting addiction into a higher risk group and monitor them more closely, that somehow you can prevent them from getting addicted. And none of that works. We really don't have a way of preventing a chronic pain patient from becoming addicted or predicting in advance who will become addicted. If you see the patient frequently, if you check the PDMP and you see that 3-4 months into this, the patient is visiting multiple doctors, that's telling you the patient is already addicted. The point at which you're capable of recognizing there's a problem, it's too late. The prescriber can get themselves out of the situation. They can say, I can't continue to prescribe to the patient because you've got a problem, but that patient is left holding the bag, and if they can't continue to get pills from that doctor, they'll go to another doctor, and if they can't get pills, they may switch to heroin. So to answer your question, we don't have a way of teaching doctors how to prescribe opioids long-term in a way in which the patient will not get addicted. The education that we do need, and we do need education, because the reason that we're in the midst of this crisis is because the prescribing took off. And the reason the prescribing took off was because the medical community was responding to an educational campaign. It was an educational campaign that misinformed prescribers about the risks, especially the risk of addiction, minimized the risks, and exaggerated the benefits. So what we do need is information that explicitly counters that misinformation, so that at the end of the day, the prescriber, whether it's a primary care doc or a dentist, is able to accurately weigh the risks versus benefits for the patient in front of them.
John, I'd like if you could address the issue of prescription drug monitoring programs. And there was some question during the first hour about the role that these play. I think that it's sort of intuitive that they might be useful in identifying a really high-risk patient, or a doctor, for example, a rogue prescriber who's prescribing, reams of OxyContin. But what are innovative ways that PDMPs can be used to better identify patients in need of addiction treatment, and to in fact link them and engage them in treatment? So there were questions from afar that we received about that, and also about interstate data sharing of prescription drug monitoring programs, best practices for PDMPs. So can you say a little bit, at least about this idea of using the PDMPs for more than identifying the rogue prescriber, but also using them to link patients to treatment?
Okay, first of all, if we recognize that you've asked me more than I can contain, in the answer you're going to give me, I'll see what
All in 30 seconds or less.
Okay, first and foremost, from the medical standpoint, the PDMP is a clinical tool that physicians should use every time they prescribe one of these drugs. And that includes not just the opioids, but the benzodiazepines, as you've heard, but and the stimulants, that came up in the first hour, and all the other controlled substances. Unless a doctor checks to see what is in the database and learns what their patient has previously obtained or not obtained, the prescriber has no way of knowing whether it's wise to proceed and to prescribe these drugs ahead of time. And so fundamentally, they should be used every time before any of the controlled substances are prescribed as a clinical tool. That's point one. Point two, after therapy is initiated, they should be continued to be used at least every 3 months, because the patients are exposed to potential risk of addiction, either through the immediate therapeutic dosage prescribed by the primary prescriber who's first looked, or by other prescribers this individual patient may have gone to in the interim. So without the access to that data, it's also to look at the total dosage and also at the synergistic impact of other prescribing. The typical case, somebody goes to a prescriber and gets a benzodiazepine for anxiety and goes to another physician for pain, and the two are synergistic and actually can kill the individual, as you've heard. So it's critical, but it's critical as a clinical tool. PDMPs have a lot of other uses, and I won't get into all of that at this point. You've touched on them very nicely in your question, Kayla.
How do we link people into addiction treatment services? Can PDMPs ever be useful in linking people into addiction treatment services?
Well, first of all, states have begun to put information on their websites and into their systems so that doctors can connect. It's really the issue of the prescriber who looks up the data, finds that they've got a patient who, based on their medical record or the prescribing record, identifies the potential need for intervention, and then confronts the patient and uses the PDMP data as a tool to present to the patient who says, I don't need any treatment, I'm not taking drugs from so-and-so. Well, according to this report, you are. What's going on? And so they actually can be used as an intervention tool. And in addition to that, the prescriber afterwards, if the prescriber is going to continue to treat the medical condition and the person goes into treatment, the prescriber can maintain observation over what the patient is going through in the way of certainly from the Suboxone perspective. Methadone is not at this point, for a methadone treatment program, is not reportable to the PDMP, but Suboxone is. So they can actually monitor the patient through treatment as well.
Great, thank you. We have just a few minutes. We're going to do a lightning round. We'll take a quick question in the back, and in the meantime, while we're getting a microphone back to her, Pat, how are we doing with automated algorithms to identify high-risk patients or doctors? Have these been validated? I mean, what's the state of the art?
Yeah, that's a great question. Just about every PDM, pharmacy benefit manager, runs algorithms in the background to try to identify individuals that are misusing or abusing or potentially fraudulently diverting controlled substances. Those are proprietary for most PBMs. Dr. Alexander and I have worked together and published the one from Prime Therapeutics. They have not been validated for the most part. Ours has been shown to actually, when used, to decrease the use of controlled substances in a volume basis, but in terms of outcomes and preventing deaths or harm, not been studied. So Dr. Alexander and I and others would advocate strongly that funding agencies like PCORI and ARC and others would spend money and their resources in studying these programs. Currently, to my knowledge, PCORI has not funded really any program to assess the impact of any controlled substance or addiction program on outcomes. So here's an agency that has a lot of money, and we would encourage that they would spend it in this area.
Thank you. Question in the back, and then we'll do a lightning round with the panelists. Yeah.
Hi. So I noticed throughout the whole program, we're very focused on physicians and on substance abusers who get their addiction from a prescription or an issue with the healthcare system. But I wanted to address the people of my generation, like the younger people who are getting to be addicts and substance abusers without ever coming into contact with a doctor, never being in the healthcare system, but still developing addiction, and addressing the fact that these can stem from underlying depression and stress and bullying that leads to the drug addiction in young people in high school or even earlier, and that these people may be getting their drugs from friends who had wisdom teeth procedures who may have gotten an appropriate prescription but still distributed illegally. And I wanted to ask, can we create more programs programs or recommendations that aren't included for school teachers or administrators, parents, or police officers to recognize the abuse in the children who never had a prescription and maybe requiring treatment programs for these individuals. DARE is a program that is currently in use or has been in my past for that, and it's currently very criticized for its effectiveness. So are there other things that we could create to prevent these addictions in the first place
Great.
that don't involve that?
Thank you for that question. Andrew, do you want to field that?
Thank you for that great question, and that really was the focus and the reason for having our recommendations around working on prevention, community-level prevention. And we need to be evidence-based, and right now there's very little evidence base about community intervention programs. There's one project, Lazarus, in North Carolina, that took a comprehensive approach to dealing with both the supply side and the demand side, and focused on engaging community stakeholders and activating communities through strategies that we know work from other problems. We have lots of successful models of community-based interventions on other problems that have been successful. So one of the recommendations, one of the important ones I think, is that we need to take those lessons learned from other problems and do more community-based intervention programs that have good outcome data and that are comprehensive.
Thank you. Chris, any thoughts about this one?
Well, I was just going to say, I think it also reflects the comprehensive nature. So there's the community-based side, but also that it's closely tied into excessive prescribing. So if they're getting it, they're non-patients, but they're getting it from patients who either didn't need it or had too much or didn't store it appropriately, that's also, focusing on prescribing will impact indirectly the population of non-patients who are obtaining it. So I think it's the comprehensive nature of addressing it that hits all of the points across the spectrum that will have the greatest impact.
Thank you so much. Well, I knew this was going to happen, and it did, which is that this time went really quickly. And so I apologize to those of you that have further questions that you wanted to ask, and I encourage you to stick around. I know for some of you this has been a little bit like drinking water out of a fire hose. If you haven't thought a lot about this topic before, and our report you can find on the event page website and download it, tweet it, send it to your mom, whatever it takes. We're happy for that to be a resource. One of the natural questions is what's next, and we've thought a lot about this. This topic is going to remain a very dynamic one and a very fluid one, and we think that there will be continued opportunities and unfortunately challenges in regulatory policy, which we didn't get to a great deal, in payer policy, which we touched upon a little bit, in clinical care and the like. With this report, we hope to stimulate all of you and other thought leaders and policymakers and communities to take action. We will work as much as we can to facilitate moving these recommendations into action by responding to requests from policymakers and other stakeholders who are seeking ways to operationalize specific recommendations. Rain Henderson has committed us to revisiting and updating this report. I joked to the dean that I didn't realize I had fully signed up for that, but we would be delighted to consider doing that in a year and convening again with all of you. And last but not least, we hope that this will inform the work of many different stakeholder groups who share our desire to see evidence-based solutions applied to reducing the incredible toll of injuries and deaths associated with prescription opioids. So I'd like to thank once again the panelists and the working group leads and all of the people, as I mentioned at the outset, the dozens of people from the Department of External Affairs and Multimedia and Environmental Services and the Clinton Foundation, all of you for helping to contribute to making this a success, and we look forward to discussing things with you. There's a reception from 5 to 6, so please join us at the Wall of Wonder and we'll keep talking. Thank you.